Hi, I'm Josh.
Hi, I'm Aimee,
Hi, I'm Nick.
and you're watching UNC Rad Stuff.
On today's episode, portable radiography.
It is our hope that after going through our presentation, you should have a good understanding of the objectives listed here, which include general information on mobile radiography, radiation safety, equipment involved, and how to correctly perform mobile exams. Now, many of you are familiar with the concept of mobile radiography, or as you may call it by its shorter name, portables. Mobile radiography is a staple at hospital institutions both large and small, providing many patients with an alternative, safer way to receive x-rays. So what exactly is mobile radiography? Why do we use it? Mobile radiography can best be described as the process of bringing a transportable imaging unit to a patient or patient location for the purpose of producing diagnostic radiographs. As mentioned earlier, mobile radiography is often used where it is safer to bring an x-ray to patient than the patient to radiology, but also in the case where x-rays are needed at a more efficient rate, such as emergency department. Other areas where you would expect a visit from portables include intensive care units, where patients are usually in non-mobile situations, surgical recovery units or PACUs, where a patient may be recovering from a recent surgery, think hip replacement for instance, or in certain nursery and neonatal units. Now, it would seem that mobile radiography is one of the more modern innovations and practices in our field today, but it actually dates back to less than a decade after x-rays were first discovered. It was created out of an urgent need. World War I was a war first. It was the first to use poison gas, first to use tanks, but also the first to use mobile radiography. X-ray was extremely vital when assessing war casualties, but it wasn't always the most readily available service to provide. Enter Marie Curie, the Nobel Prize-winning scientist, who decided to bring radiology to the front lines in 1914. She outfitted donated automobiles and trucks with specially fitted generators to provide the basis for X-ray production. And also, films would be developed in the back in makeshift darkrooms of the vehicles. Along with over 150 female volunteers that she trained, Curie was able to inspire a practice that is estimated to help image over 1 million soldiers during the conflict. It's safe to say that the landscape of portables has changed drastically since its origins. That's not to say that it's without its challenges despite the modern convenience. The benefits include the aforementioned safety to the patient, but also with the rise of digital radiography, images can be viewed shortly after acquiring them, and they can deem to be acceptable or not. A few caveats that come with mobile radiography is that patients with certain body habituses or certain obese patients, quality radiographs may take more thought to produce, both in terms of technique and positioning. Since portables don't have all the radiation safety precautions as normal X-ray units, it should make sense that mobile radiography is responsible for the highest amounts of occupational radiation exposure. But there are ways to manage that for both you and for your patients. So when performing portable exams, the technologist should always wear lead apron and vest, and the patient should be shielded in the same manner as if they were in the radiology department. You also want to make sure that everyone is out of the room, or if you're in an open space or bay such as a PACU, that others in the vicinity are notified that an exposure is going to be made, and they should be notified right before the exposure is made. Before making the exposure, you want to make sure that you're positioned properly when doing a mobile exam to limit yourself to the amount of scatter radiation being produced. And the best way to do that is to distance yourself 6 feet away from the patient, X-ray tube, and the primary beam, as again, this will limit you to the amount of scatter radiation being produced. That's also an important thing to realize when you set up your portable machine, that you have room to stand that 6 feet away. Another way that you can limit excessive radiation exposure to the patient is to be mindful of your source to skin distance, or SSD. There are actually federal regulations in place that prohibit an SSD from being under 12 inches or 30 centimeters for the patient. Now, when you're performing an exam that uses a horizontal beam, such as a decubitus or an upright chest, you want to make sure that you still distance yourself 6 feet away from the primary beam, but you want to do so this time at a right angle. So if you're doing a decubitus, for instance, you want to stand at a right angle to where the x-rays hit the IR, because that's where the scatter radiation is produced. So you can stand either 6 feet away at the head of the patient or at the foot of the patient when performing the exam. If you're performing an upright chest, for instance, it would still be the same thing. You'd be 6 feet away from where the radiation hits the IR and the scatter radiation is produced. So you could be 6 feet away either to the left or to the right of the IR. And by doing this, this allows you to limit yourself to the amount of scatter radiation, so you aren't exposed as much, or if at all.
Now, Nick's told you plenty about the basics and the origin of mobile radiography, but what exactly makes it mobile? Well, every portable unit from every manufacturer is going to be a little bit different, but like cars of different makes, most of them have the same key components. Generally speaking, the entire device will be mounted in a motorized wheeled cart. There will be a display for altering exposure settings, and if digital radiography is used, it can be used for viewing, editing, and even sending images from the patient's bedside. Mobile units can also use computed radiography, but regardless of the type, will have some sort of storage or holding device for the image receptors. A movable tube stand instead of collimators allows for aiming and framing of the beam in many different directions. The exposure switch will be on a cord, to be held from a distance as mentioned by Nick. The mobile unit's generator is located on the main cart. There are several types of X-ray generators that could be on the cart, all with slightly operational differences. Direct power requires the unit to be plugged into the wall, but the radiation output is subject to voltage changes and may make the radiation output fluctuate. Capacitor discharge also requires a wall outlet, but outputs radiation more consistently, akin to a single-phase generator. Battery-powered generators don't require a wall plug at all, and generate consistent radiation output similar to a three-phase generator. However, they require periodic charging in order to function continuously. High-frequency generators require a wall outlet, have consistent radiation protection, and are generally more lightweight than other generators. Grids are also an important component of mobile radiography equipment, although they aren't part of the machine itself. They serve the same function that grids in stationary radiography do, to reduce scatter radiation and improve image quality. In mobile radiography, however, it is important to keep in mind that the IR and grid will be positioning in all manners of orientations, so keeping the grid level or perpendicular to the CR and maintaining an ideal focal range are paramount to proper grid usage. Otherwise, using a grid can hurt image quality just as much as it intends to help. Mobile grids can be oriented longitudinally or transversely, and are typically housed in protective casings that clip onto the IR. How the equipment is utilized makes all the difference in obtaining quality images under difficult scenarios. One factor that can be addressed with equipment and orientation is the anode heel effect. As some may know, the anode heel effect essentially results in reduced image density under the anode side of the tube due to the angle of the anode. One should orient thicker parts toward the cathode in order to compensate. For example, positioning the proximal aspect of the femur in a portable X-ray closer to the cathode end. This will not always be possible due to the sometimes unmaneuverable mobile unit in closer quarters. Something that can be readily compensated for by the equivalent is patient part thickness. Different body habitus, from the thicker and sometimes obese hyperstenic to the extremely thin and lanky astenic, require different radiographic exposure settings. Mobile units will generally have built-in anatomically preset radiographies, or APRs, for different sized patients on average, and it will be up to the technologist to further determine technique based on each individual case. Calipers and half-value layers can be used to more precisely determine technique.
The next part of our presentation will be about performing a portable exam. There are several important parts to remember. These include identifying the patient, assessing their condition to figure out the safest way to proceed, being cautious with any equipment connected to the patient, and protecting yourself and the patient. The most important part of mobile radiography is that the technologist does not spread germs from one patient to another. Staying highly aware what the machine is touching and making sure to clean is very important. This is why you should confirm the patient's identity and tell them about the exam before you bring the equipment in, especially if that patient has any precautions. This way, if you have the wrong patient or if they refuse to get the x-ray, you haven't unnecessarily exposed the machine to those germs and increased the risk of carrying those germs to the next patient's room. After their identity has been confirmed and they consent to the exam, you can bring the machine in and begin setting up. Now is the time when you need to assess the patient's condition and figure out the best way to proceed. If you need to slide the board underneath the patient, it is always good to warn the patient of the cold hard board before putting it under them so they aren't as shocked. If you are imaging a limb, it is important to remember that a technologist should never move a limb that has been operated on or is broken unless the nurse, physician, or sometimes the patient grants permission. Trauma variations will be very common for portable patients since most are unable to move the part of interest. Depending on the anatomical part that you are imaging, you should park the x-ray machine in different spots. If the patient is seated, the base of the machine should be towards the foot of the bed, about where the X is. For lateral, decubitus, and supine radiographs, it is best to place the X-ray machine parallel to or directly perpendicular to the bed in order to allow the greatest ease in positioning the X-ray tube. The radiographer may have some difficulty aligning the X-ray tube parallel to the IR while standing at the side of the bed. Try stepping back and looking at it from the foot of the bed to check the positioning of the X-ray tube and IR alignment to make sure the tube isn't tilted. The primary X-ray beam must be collimated no larger than the size of the IR. As you are adjusting the patient's position, you need to be careful of any equipment connected to the patient. As a technologist, you will need to know what different wiring, tubing, and devices are in order to safely move them out of the way of the central ray. If there is something within the light field that cannot be moved, you should make a note of it. Depending on the device and what anatomy it is blocking, it may be necessary to angle the central ray or shift the IR to obtain the best radiograph possible. It is also extremely important to watch out for any lines that may be caught when you are lowering the railings on the bed to slide the IR beneath the patient. Lastly, it is extremely important to protect the patient, visitors, and yourself as much as possible from radiation. Like Nick said earlier in the presentation, visitors should step out of the room, the patient should be shielded if possible, and the technologist should move away from the machine. After the exposure has been taken and is ready to be sent to PACS, you need to clean. When putting the IR back into the X-ray machine, you need to be sure that you are not touching it with your gloves. You can do this by letting the IR slip out of the clear covering back into its pocket. You should throw out the covering and the gloves. Once you are out of the room, you should wipe down anything you touched with your gloves after touching the patient to make sure you're doing your part in stopping the spread of germs between patients. We hope that you will be able to apply what you have learned from our presentation when doing your next portable radiograph. Thank you.